afternoon. Your presenter is Licentiate Medical Officer Mr.Ngoma Austin, and today we'll be discussing pharmacology, particularly the antiretroviral drugs. This is a continuation of our discussion that we had started previously on antivirals. Okay, so without further ado, let's go straight into our discussion. So, looking at the pharmacology of ARVs, the antiretroviral drugs, we need to first classify the different antiretroviral drugs that we have. Okay, so the first one is the nucleoside and the nucleotide reverse transcriptase inhibitors. Then we have the nucleoside, non-nucleoside reverse transcriptase inhibitors. We also have the protease inhibitors, we have the entry inhibitors and the integrase inhibitors. Okay, so when we are looking at ARVs, we'll be looking at these classes into a bit more detail so that we have an understanding on how these drugs work. Okay, now for us to understand this pharmacology better, we need to understand how the life cycle of the virus, when it is introduced into a human host, works. Okay, so the first thing is that once a virus has entered the bloodstream, okay, once the virus has entered the bloodstream, the first thing that it is going to do is that it is going to bind to and fuse and enter the cells, in this case the CD4 cells. Okay, so the first step is binding and entry. Once the cell has bound to the cell membrane, the next thing is that it is going to fuse and then it is going to penetrate, or it is going to enter, releasing its inner contents, which is the RNA, the protein, and so on and so forth, just like the previous life cycle we had discussed. Okay, so now when these contents are released inside, there is going to be the next step, which is reverse transcription, and this is of course facilitated by the machinery of the CD4 cell. Okay, so as it is transcribing any other DNA material within the cell, it is going to transcribe the HIV material as well, making more copies. So after reverse transcription is that this transcribed DNA of the virus is going to be integrated. Okay, it is going to be incorporated into the cell's DNA. Okay, so integration is the third step. Once it has been integrated, as the cell's machinery continues on, it is going to transcribe more DNA material. In the actual sense, the cell thinks as though it is producing more material of the cell, but since the HIV virus has also incorporated its DNA to part of the DNA of the cell, the transcription is going to produce more material that has been infected by the virus. Okay, so the third step there is integration and then transcription. Now, after this transcription has occurred, the next thing is that the cell will start to assemble the newly formed proteins, RNA, and so on and so forth. Okay, so this is the assembly point, and this one is facilitated by the enzyme protease. After the assembly, there's going to be release of the new virons or the new contents that have been assembled. Okay, so basically there are 6 steps that we'll be looking at. And these 6 steps are the key concepts of our discussion today, as in how these pharmacological medications will be working. All right. So the first class of drugs we'll be looking at are the nucleoside reverse transcriptase inhibitors, or for short form we'll be calling them the NRTIs. Now, NRTIs are nucleoside or nucleotide analogs, and these ones include the abacavir, emtricitabine, lamivudine, stavudine, tenofovir, zidovudine. Okay, so these are some of the examples that we can give of the nucleoside reverse transcriptase inhibitors. So now, just from the name there of this classification of these drugs, when we go back to our life cycle, to our life cycle of the viron, we can see that the second step here is the one we are calling reverse transcriptase. Okay, now this is the step in which these drugs are going to be working on. So they are going to be inhibiting this process, like I had explained, because reverse transcriptase is where more of the RNA that has been produced, that has been released into the cell by the virus, is going to be multiplied. So the NRTIs are considered the backbone of antiretroviral therapy and are generally used in combination with other classes of agents. So in whatever medications that you would want to combine, you are not going to forget the addition of the NRTIs, because these ones are basically the backbone of our management when it comes to ARVs. So we are going to be combining the NRTIs with other medications such as the non-nucleoside reverse transcriptase inhibitors, or NNRTI, as well as the protease inhibitors, the integrase inhibitors, and so on and so forth. Okay, so NRTIs are generally given in pairs. So when you're going to be administering these drugs, you're going to be combining either abacavir with emtricitabine plus any of the other ARVs that have been made available to you. Now, what is the mechanism of action of these drugs? Okay, so we are saying NRTIs are phosphorylated by host enzymes to give us the 5-triphosphatase, which complete the equivalent host cellular triphosphates for incorporation into the viral DNA. Now, what does this mean? Okay, so when you administer these drugs, okay, remember we said phosphorylation is sort of being activated by the enzymes of the cell. So now this drug has to be activated by these enzymes to give us this 5-triphosphate. Okay, and this one is going to give us an equivalent to the host cellular triphosphate in order to incorporate it into the viral DNA. Now, once it has been incorporated, okay, here we are saying their incorporation is going to cause premature termination of viral DNA synthesis. So that reverse transcription, which is the synthesis of the other DNA of the cell, is going to be terminated prematurely. So even before the reverse transcriptase goes on, this medication, by virtue of it being incorporated into the cellular DNA, is going to terminate this process. Okay, thereby it is going to inhibit the viral replication. Okay, additive or synergistic with other classes of ARVs. So when we combine it with other ARVs, in short, we are going to have more desirable results. Now, there has been resistance that has been recorded in most parts of the world towards this drug. So what is the mechanism of drug resistance? So two distinct mechanisms are involved in HIV resistance to these drugs. One, impairment of the incorporation of the analog into the DNA. So we have been told that for us to have the perfect mechanism being elicited by these drugs is that it has to be incorporated into the host DNA. Now, there has been impairment to the incorporation of the analog into the DNA. That is the first thing that is going to cause resistance, because if there is no incorporation, this premature termination of the viral DNA synthesis will not take place, meaning the virus is going to go ahead and replicate and multiply and so on and so forth. Secondly, removal of the analog from the prematurely terminated DNA chain. Okay? Removal of the analog from the prematurely terminated DNA chain. So you terminate this process prematurely, but it is not removed. That is what is going to cause another form of resistance, because if it is not removed, still the transcription process may go on, and the premature synthesized DNA might go ahead and develop into something more infectious, and so on and so forth. Now, these occur as a result of mutations leading to change in the structure of the reverse transcriptase. Okay, now the side effects of the NRTIs, or the nucleoside reverse transcriptase inhibitors. So, in general, all NRTIs are going to have adverse effects, including lactic acidosis, severe hepatomegaly with steatosis. Now, going to them one by one, as in those examples that we have given previously, we are saying zidovudine has got side effects of bone marrow depression, GI intolerance, cardiomyopathy, and myopathy. Stavudine has got side effects of peripheral neuropathy, lipodystrophy, and hepatotoxicity. Abacavir has a side effect of hypersensitivity reactions, okay, as well as increased myocardial infarctions. Tenofovir has got side effects of nephrotoxicity, osteoporosis, exacerbation of hepatitis B with discontinuation. Okay, this statement simply means if somebody has got hepatitis B and you are administering tenofovir, okay, the moment you stop giving tenofovir, it is going to make the condition of hepatitis B worse. Okay, lamivudine has got side effects of pancreatitis, while amitriptyline has got side effects of hyperpigmentation. Okay, now what is the drug and food interaction of these NRTIs? Okay, let's just take a look at a few examples here. So when you give zidovudine together with stavudine, which is D4T, it is going to inhibit intracellular phosphorylation of each other. So the intracellular activation that is supposed to be taking place when you give these two drugs together is going to act as an antagonistic effect on both of the drugs. Okay, so zidovudine will be blocking the activation of D4T or stavudine will be blocking the activation of zidovudine. Hematologic toxicity of zidovudine is increased by ganciclovir. Okay, we talked about ganciclovir previously in our lecture. So when you give zidovudine with ganciclovir, there's going to be a hematologic toxicity, or there's going to be toxicity in the blood. Alpha interferon are going to give us the same effect when combined with zidovudine, as well as cytotoxic drugs and radiation. Zidovudine is antagonistic with stavudine, doxorubicin, as well as ribavirin. Okay, so all these drugs are going to be interacting with each other. You need to ensure that once you are administering or once you're prescribing these drugs, you don't give them together. Abacavir, zidovudine, amitriptyline, lamivudine, stavudine, and tenofovir may be administered with or without food, or in short, the NRTIs can be administered with or without food. Now let's go to our second class of drugs here. Okay, so we are talking about the non-nukes, the non-nucleoside reverse transcriptase inhibitors. Okay, examples of these ones we can give are efavirenz, nevirapine, and etravirine. Okay, these are some of the common examples in our setting today. Now, what is the mechanism of action of the non-nukes? Don't get it here. These drugs, just like the nucleoside reverse transcriptase inhibitors, are also working to inhibit the reverse transcription, just that these ones do not have the nucleoside component in them. So, the non-nukes are chemically diverse compounds that bind to reverse transcriptase near the catalytic site and denature it. Okay, so there's an enzyme, reverse transcriptase, that facilitates the reverse transcription to take place. So now, these drugs are going to be working on this particular enzyme and are going to denature it, they're going to destroy it, meaning this enzyme is not going to be able to carry out its work on this particular viron. Okay, so it is going to bind to a site on the reverse transcriptase, different from the nucleoside reverse transcriptase inhibitors. These ones are non-competitive inhibitors of HIV-1 reverse transcriptase. That is, they do not compete with nucleoside triphosphates and do not require phosphorylation. Okay, remember that one, we were talking about phosphorylation and all those things, but here we are talking about them only acting on the reverse transcriptase, especially with the HIV-1. They do not inhibit HIV-2 reverse transcriptase. That is one thing you need to remember. So if you establish that this patient that has come to your OPD or wherever you'll be working from, that this patient has got HIV-2, you giving them efavirenz, nevirapine, and or any of the non-nukes is not going to do them any justice, but it's going to just cause drug toxicity. So now, NRTIs and PIs exhibit additive synergistic activity to NNRTIs against HIV-1. Now, when we talk about drug resistance in this particular class of drugs, is that in drug-sensitive viruses, NRTIs bind to a pocket next to the active site and block the polymerization of DNA by reverse transcriptase. Okay? So, NRTIs are going to bind to a pocket next to the active site and block the polymerization of DNA by reverse transcriptase. This is how the drug resistance is going to be coming in. In drug-resistant viruses, mutations are going to prevent the binding of NNRTIs to their binding site, allowing DNA polymerization to proceed. So the first point here is simply explaining what is supposed to take place under normal circumstances. But now, when it becomes resistant, the mutation is going to prevent this binding that we are talking about, the binding to the protein next to the active site. Adverse effects include, so for efavirenz, neuropsychiatric effects. So your patients will come in complaining of insomnia, okay, dizziness, amnesia, and especially nightmares with efavirenz. Efavirenz, nightmares are the most common side effect that these patients are going to complain of. Then hepatotoxicity, skin reactions, as well as gynecomastia are other side effects that these patients are going to complain of. With nevirapine, which is another common NNRTI that we have in our setting today, hepatotoxicity and skin reactions are the side effects, including Stevens-Johnson syndrome and toxic epidermal necrolysis. Nevirapine is also associated with hepatotoxicity or serious rash and are more frequent in women than in men and are more likely to be seen in women with CD4 counts greater than 250 or in men with more than 400 microliter. Hepatitis B or hepatitis C co-infection also predisposed to hepatotoxicity. So this drug is therefore contraindicated in patients who have hepatic impairment or liver problems. So what are the contraindications? We do not give non-nukes in patients who have hypersensitivity reactions, in patients with concurrent administration of drugs that depend on cytochrome P450 for metabolism and induce or inhibit cytochrome P450, because if this drug is being administered, you know that it has got serious effects on the liver, and one of the side effects that we have learned from nevirapine is that it has got serious effects on the liver. Okay, drug interactions. Nevirapine induces CYP3A and increases metabolism of protease inhibitors, estrogen-containing contraceptives, and ketoconazole or rifampicin. Efavirenz also induces CYP3A4 in that it increases metabolism of drugs metabolized by the enzymes, for example, the protease inhibitors. Cytochrome P450 inducers like rifampicin increase metabolism of non-nukes, okay, meaning it will reduce their efficacy. Retroviral. Retroviral is structurally different from efavirenz and nevirapine. It is specifically designed to be less susceptible than other non-nukes to mutations that lead to resistance. So this is a drug that has been specifically designed to overcome any form of drug resistance that may come in. Okay? This is what we are trying to explain here. So this is a drug that has been specifically designed for that particular reason. Okay. In contrast to other non-nukes, more than one resistance mutation needs to develop in order to bring about resistance to retroviral. So you see that resistance towards this drug has to be a complex procedure for the virus to go through, which is why retroviral is like our go-to, our superhero once we have the virus developing resistance, because this one has to go through quite a process for it to develop resistance. Retroviral is indicated for the treatment experienced adults who have evidence of viral replication and HIV strains resistance to non-nukes, just like we have explained, and other ARVs. Okay, so side effects here include hypersensitivity reactions, that includes skin reactions and hepatitis. Retroviral is a potent inducer of CYP3A4, thus it should not be given with other non-nukes and boosted protease inhibitors or atazanava, because you're going to have serious liver damage. Protease inhibitors, okay? These ones include atazanava, darunava, lopinava, ritonava. At least these are some of the common ARVs from this class that we have in Zambia. Now, their mechanism of action is that in HIV, In the mRNA transcribed from the provirus is translated into large inactive polyprotein precursors. HIV protease enzymes cleaves to these precursor polyproteins to release the structural proteins and enzymes needed to produce mature infectious virons. So that's like the last step in our HIV life cycle. Okay. It is the one that is responsible for assembling and producing new virons. Okay, this is what this statement here is trying to explain. Okay, so the protease is the enzyme that is responsible for ensuring that this process is carried out. Now, in the absence of a function of protease, viral particles are produced, but they are immature and unable to replicate. So it's like these particles are just going to be produced prematurely, and they're not going to be able to function as a virus. Okay, so in short, it won't be a virus, it will just be particles that have been produced. Now, protease inhibitors have a strong affinity to the active site of the HIV protease and inhibit the catalytic activity. So protease inhibitors, just like the name itself states, it inhibits the enzyme protease from carrying out its work. Now, resistance to PIs is the consequence of amino acid substitutions on the protease. So on the protease itself, there are going to be some substitutions, especially on the amino acids. These amino acid changes modify the number of the nature of points of contact between PIs and the protease, thereby reducing their affinity to the enzyme. So if these, it's like the receptors have changed. So now when you administer this drug has nowhere to bind, meaning it will not have its effect on the enzyme. Okay, so all PIs are metabolized by cytochrome P450, like we have already learned or we have already discussed from the other ARVs. They all inhibit cytochrome P450. They induce cytochrome P450. Okay, reduce plasma concentrations of inducers of cytochrome P450 reduce plasma concentration of PIs. So if you've got any drug, for instance, rifampicin, this patient is taking rifampicin, and then you choose to give PIs, just know that it is going to be reducing the plasma concentration of PIs because cytochrome P450 inhibits, cytochrome P450 metabolizes the PIs. Inhibitors of cytochrome P450, on the other hand, increase the plasma concentration of PIs. Okay, ritonavir is a very potent inhibitor of CYP34 and inhibits the metabolism of other PIs. So it is used in subtherapeutic doses as a pharmacoenhancer or a booster, okay, to raise and maintain plasma concentrations of other PIs. Okay, so when you find ARVs being prescribed as LPV/R, that simply means lopinavir has been boosted by means of using ritonavir on top. So lopinavir boosted with ritonavir. Okay, so now PIs should be administered with food. Okay, the major adverse effects here include these agents cause a syndrome of altered body fat distribution, insulin resistance, and hyperlipidemia. Okay, OPIs cause fatigue, GI disturbances such as diarrhea. Ritonavir is the most poorly tolerated PI. Okay, its adverse effects include headache, taste disturbances, okay, hyperglycemia, and so on and so forth. Lopinavir has got side effects of persistent diarrhea and CNS effects like dizziness, mood disorders, and so on and so forth. Atazanavir has got GI disturbances, indirect hyperbilirubinemia, jaundice, ECG abnormalities, nephrolithiasis, and risk of premature delivery as its side effects. Darunavir is a protease inhibitor designed to be active against HIV resistant to the current first generation protease inhibitors. Okay, so this one is also our other superhero, but in the protease inhibitors. Once the HIV virus has developed resistance to the first line protease inhibitors, we've got darunavir as your superhero to save you. Okay, so darunavir is active against HIV with high level resistance to other protease inhibitors. Resistance to darunavir develops more slowly than any other protease inhibitor, which is why this one is saved as a drug of choice when there is resistance. Okay, darunavir is administered with boosted ritonavir. Darunavir is therefore metabolized by the CYP3/4 system in the liver. Thus, there is potential for significant interaction with other drugs that are metabolized by the same enzyme. Lopinavir ritonavir decreases serum level of darunavir. Therefore, avoid concomitant administration with this drug. So, when you're giving darunavir, don't give lopinavir ritonavir because it is going to be inhibiting its action. Adverse effects include diarrhea, nausea, rash, headache, hepatitis with pre-existing liver disease, severe skin reactions, and hypersensitivity reactions. Entry inhibitors. Okay, these ones are inhibiting the first step in our life cycle. These ones include enfuvatide and maraviroc. They're not very common in our setting today, but they're there. Entry inhibitors prevent HIV from entering the human cells. Okay, self-explanatory there. There are several key points that are involved in the HIV entry process. Okay, so this is an important point to note. Okay, so CD4 is a cell. Okay, is a defense cell. A protein receptor is found on the surface of the helper T cell in the human system. Okay, also called CD4 plus T cells. Now we have got the glycoprotein 120, which is a protein on the HIV surface that binds to the CD4 receptor. Okay, so we are looking at the surface of the virus and the surface of the cell. And then we also have another chemokine co-receptor, R5, CCR5, okay? This is a second receptor that is found on the surface of the CD4 plus T cells. And then we've got the CXCR4, okay, another chemokine co-receptor that is found on the CD4 plus cells. Then glycoprotein 41 and HIV glycoprotein is closely associated with glycoprotein 120 that penetrates the cell membrane. So these receptors are going to be binding on the receptors of the receptors, the GP120 and the GP41 are the ones that are going to be binding on the CCR5 and the CXR4 on the CD4 cells in order to facilitate the binding, which is the first thing. Okay. Entry fusion inhibitors. Enfuvatide, okay, T20. Enfuvatide is a synthetic 36 amino acid peptide that interferes with the entry of HIV-1 into cells by inhibiting fusion of the virus and cellular membranes. It binds to the glycoprotein 41, which is a glycoprotein that is found on the HIV surface, a protein on the viral membrane, preventing the fusion of the viral cellular membrane, thereby inhibiting entry of HIV into the CD4 cell. It has additive synergistic effect when combined with drugs of other ARVs. Okay. HIV-1 clinical isolates resistant to NRTIs and NNRTIs as well as PIs have been found to be susceptible to enfuvatide. So if you've got resistance to these drugs, enfuvatide can work better for you. What are the indications of this drug? Okay, HIV infection in combination with other ARVs for resistant infection, or for patients intolerant to other ARV regimens. So if there is resistance to other ARVs, you can give enfuvatide, and if there is a patient that is intolerant to the ARV regimens, you can give enfuvatide. Now, due to its cost and inconvenient dosing regimen, enfuvatide is reserved for salvage therapy in patients with multi-drug resistant HIV, and it is given subcutaneously. So because this drug is not cheap and the dosing is very inconvenient, this drug is reserved, okay, for this particular class of patients. Adverse effects include local injection site reactions because we're giving this one subcut, hypersensitivity reactions, headache, insomnia, anorexia, asthenia, peripheral neuropathy, depression, and pancreatitis. What are the contraindications if a patient is known to be hypersensitive or they've got hypersensitivity reactions? Pregnancy. We can use this drug in pregnancy if it has been clearly needed. Okay, so what do we mean when we say clearly needed? For example, when they have got these indications here, if there is resistance or if they are intolerant to other ARVs. But if a woman is breastfeeding, you do not give enfubatide. Maraviroc. Maraviroc is an entry inhibitor. This one is going to bind to CCR5 receptor on the membrane of the human cell, such as the CD4. So now, when it binds to this cell, it is going to prevent the interaction of the HIV glycoprotein 120, HIV1 particularly, glycoprotein 120, and the human CCR5, which is necessary for the entry into the cell. HIV can also use another co-receptor, the CXCR4, which Maraviroc does not affect. Maraviroc does not prevent HIV1 entry into CXCR4 tropic or duotropic cells. So a tropism test must therefore be performed to determine if the drug will be effective. What it means is that you have to check if the cells have got both these receptors or they just have the CCR5. Because if they only have the CCR5, you know that the drug will work. But if they have both, the HIV will be blocked from the CCR5, but it will work on the CXCR4 and still cause the infection. Maraviroc is indicated for CCR5 tropic HIV infection in combination with other ARVs in patients previously treated with ARVs. Okay, so just like I have explained, Maraviroc is not recommended in patients who have dual or mixed tropic CXCR4 tropic virus. Again, just like I have explained, because if they have got dual, the drug will be blocked from one receptor, but it will go ahead and use the other receptor for entry. Use of Maraviroc should be based on the treatment history and tropism assay results. Okay. Adverse effects include hepatotoxicity, okay, and may be preceded by systemic allergic reaction, pruritic rash, eosinophilia, dizziness, postural hypertension, and increased risk of cardiac ischemic events like myocardial infarctions. Integrase strand transfer inhibitors. Integrase strand transfer inhibitors. These ones are working on the integration of the viral DNA into the host DNA. Okay. The mechanism of action is that they inhibit the final step in integration of strand transfer of the viral DNA into the host DNA, okay, like I have explained. Now, raltegravir is indicated when it is approved for therapy of treatment experienced patients with evidence of viral replication despite ongoing antiretroviral drug therapy. So in short, we may narrow this down to patients who have started exhibiting treatment failure. Okay, so you're giving ARV therapy, but replication is still ongoing. You're giving ARVs, but their viral load is not going down. So you can give raltegravir. Adverse effects include nausea, headache, diarrhea, myalgia, myopathy, rhabdomyolysis. Okay. Limited options for substitutions in the event that serious toxicity occurs. So this one, when there's toxicity, you don't have a lot of options. Dolutegravir, another integrase inhibitor. This one, the indications are as follows. It is approved for use in treatment of treatment-naive HIV-infected adults and HIV-infected adults who have previously taken HIV therapy, including those who have been treated with other integrase strand transfer inhibitors. It is also approved for children ages 12 years and older weighing at least 40 kgs who are treatment naive or treatment experienced but have not previously taken other integrase strand inhibitors. Adverse effects include insomnia and headache. Serious adverse effects include hypersensitivity reactions and abnormal liver function. Now, what are the goals of antiretroviral therapy, ART? There are 5 goals, okay? So we need to have long-term viral suppression. Once we've suppressed this virus, there's going to be restoration and preservation of the immunologic function. Once the immunologic function has been restored, there's going to be an improved quality of life. Improved quality of life means that there's a reduction of HIV-related illnesses and death, as well as reduction in transmission to others. Okay, so 5 goals of therapy are very important. You need to remember those. Now, what are the general principles of ARVs or antiretroviral therapy? ART should be initiated in all individuals living with HIV regardless of the WHO clinical stage at any CD4 cell count. Use of combination of 3 or more ARVs to maximize the efficacy and reduce the development of drug resistance. So you need to ensure that once you're prescribing these drugs, you need to give them at least as a triple therapy, with the nucleoside reverse transcriptors being your backbone of your management. You need to maximize adherence to ARV regimen just to avoid treatment failure, because treatment failure is going to be complicating our lives as clinicians. Sequence the regimens rationally, okay? So appropriate first-line regimen and subsequent switching to other ARVs in case of toxicity of treatment failure. So you as a clinician need to familiarize yourself with the current HIV guidelines as to which drugs are supposed to be used in the first line, second line, third line, and so on and so forth, so that you can sequence these regimens rationally. When do we change an ARV drug? Okay, a specific ARV drug may be changed due to 1, if there is toxicity such as anemia, peripheral neuropathy, lipodystrophy, liver or renal abnormalities. So toxicity in those lines. 2, if there is intolerance or unresolved and prolonged adverse effects. 3, if there is poor adherence. The change is indicated only to simplify the dosing schedule and to improve adherence in this case. 3, if there is occurrence of active TB, because you need to understand the drug interaction. We already talked about the interaction of rifampicin with various classes of ARVs. Then the fifth point is that we need to understand when there's treatment failure, we need to change the ARVs. So when patients are substituted to alternative regimen, the goals are to achieve HIV viral suppression and avoid adverse events to optimize resistance. Now, there is a condition that is known as immune reconstitution inflammatory syndrome, also known as IRIS. Okay, so IRIS is an exaggerated inflammatory reaction from a reinvigorated immune system presenting as unmasking of previously subclinical opportunistic infections or clinical deterioration of pre-existing opportunistic infections or development of autoimmune disease. Such a mouthful. Okay, in short, IRIS is just an exaggerated inflammatory response, okay, resulting from an immune system presenting as unmasking of a previously subclinical opportunistic infection. So if a patient had a subclinical opportunistic infection, and then you start administering this IRIS, and then that infection suddenly becomes worse or it becomes severe, that is what we are calling IRIS. So there is an exaggeration of that condition. Okay. The onset is usually within 2 to 12 weeks after starting ARVs. And the frequency is about 10% among all patients on ART and about 25% among ART initiated with CD4 more than 50 cells. What are the risk factors? Okay, initiating ART close to diagnosis of an opportunistic infection. Initiating ART when the CD4 count is less than 50 cells per millimeter cubed, and rapid initial fall in HIV-1 RNA level in response to ART in patients with low CD4 counts. So those are some of the risk factors. Commonly seen with TB, cryptococcal disease, Kaposi sarcoma, Mycobacterium avium complex infection. Okay, so that is about iris. How do we manage this iris that we are talking about? Okay. One, you need to have a high index of suspicion with early complications. So you notice that you initiate somebody on ARVs and then they start exhibiting early complications. You need to have suspicion, you need to have iris in mind, okay? ART should be continued. If ART continuation is impossible, rather, temporarily interrupt ART and restart the same regimen after the opportunistic infection or the inflammatory condition is treated. So, temporarily stop, treat the condition, and then continue with the same regimen. Diagnose and treat the opportunistic infection or inflammatory condition. Corticosteroid treatment is in moderate to severe cases. So here you can give prednisolone, which is a corticosteroid, at a dosage of 0.5 to 1.0 milligrams per kg per day for 5 to 10 days. Okay. With that being said, we come to the end of our lecture and our session today. If you have any questions, please feel free to get in touch so that we can all benefit from this. Thank you very much. Hope you have a wonderful